All right. Welcome all
right.
this evening. And Kathy, please feel free to kick
Okay.
us off.
Thank you. Well, good evening, and thank you for joining us at the Public Health Museum for a presentation titled Tuskegee Racism, Healthcare Access, and Vaccine Hesitancy. My name is Catherine Demoto, and I'm the president of the museum's Board of Trustees. In the past, this kind of event would have been held at our museum in Tewksbury, Massachusetts. But we have embraced the virtual environment as a result of COVID-19, and we're reaching out to a wider audience. Many thanks to Ashlyn Rickford-Werner and Carrie Nagel for the technical assistance, and Paige and Pink and Ashlyn for all the work with publicity. For those of you who are not familiar with the museum and have not been able to visit, I just want to take a short time to give you a little bit of an overview of the America's first public health museum. The museum is a nonprofit organization located on the campus of the Tewksbury Hospital in Tewksbury, Massachusetts. And this hospital was founded as the state almshouse in 1854 and has been in continuous operation since then. The hospital's patient population has evolved, reflecting the needs of the Commonwealth and initially treating many immigrants who often had infectious diseases such as tuberculosis, smallpox, typhoid fever, but also serving as a last resort for patients in need of shelter and supervised care. Currently, care is provided for up to 300 medical and psychiatric patients. And we're very pleased that one of our board members, Ashlyn, has just published a book on the history of Tewksbury Hospital that is now available, and you can purchase it through the museum. Take a good look, it's great. The museum opened in 1994 and is located in one of the National Historic Buildings that was built in 1894. We have exhibits that cover a wide range of public health topics, infectious diseases, including malaria, smallpox, TB, polio, and we have mental health, nursing, many, many things. So we would like you to come visit, and we are open. You do have to register and go to our website and sign up, and you can come in and see it. I also like to mention that we have a wide range of volunteer opportunities, so you can visit the website and look to that. And just so you know, the mission of the museum is to celebrate the history and achievements of public health and to preserve the past, inspire future public health professionals, and educate the public. We are also wanting to advance the future of public health through partnerships with academic institutions. So, as I said, please visit our website, publichealthmuseum.org, and you'll get all the details of hours and everything else. Now I'm going to turn the program over to Dr. Al DiMaria, a board member and former medical director of the state lab. Al?
Thank you, Kathy. I see, do you see that message from Karen? I think she has.
Yeah, Karen, you can feel free in the Q&A or in the chat, you can drop your question or your comment. Feel free to add that in there. Let's see, I don't know if I can.
Okay, welcome. Good evening. And tonight we're going to talk about the Tuskegee Syphilis Study. It's something that often comes up in a variety of circumstances over the years, and it certainly has come up once again in light of the murder of George Floyd and a variety of other incidents that have not only gone on last year, but for many years, as well as in respect to the COVID pandemic. The study lasted 40 years. There were 600 men who were involved, and the impact went far beyond that on their families and many other people. And it's been considered a metaphor for racism, government malfeasance, and physician arrogance. But tonight we're going to sort of go over what it was, what it wasn't, and put it in a context. Because I think there's been a lot of confusion. There's been people sort of see it in a way that is understandable, but maybe not what they should see in it. So we wanted to take this opportunity to have two people with particular perspectives on Tuskegee and the broader implications and context. So today we're very happy to have Professor Susan Mokatoff Reverby, who is the Marion Walter McLean Professor of the History of Science of Ideas, Emerita, and Professor of Women's and Gender Studies, Emerita at Wellesley College. She has had a long and distinguished interest in this, productive interest in Tuskegee and a variety of other topics. In 1987, she wrote Ordered to Care, a book on the history of nursing, which I had reason to reread recently, and it's a wonderful book. I know we have a lot of nurses on tonight. It's a great book to read. It won the Lavinia Dock Award from the American Association History of Nursing. But more pertinent is your 2009 book, Examining Tuskegee, the infamous syphilis study and its legacy, which was part of the John Hope Franklin series in African American history and culture. And that's another book it's a wonderful book. The story is, it's not a happy story, but it's told with great sensitivity and great skill. And quite frankly, it reads like a novel. And so I'd highly recommend that if you haven't read it. She also, in the course of her research, found an archive of documents related to another study in Guatemala. And this was also by the Public Health Service, in which people were actually given sexually transmitted infections as part of the study. And in both those cases, she was involved in commission in 1996 and in 2010 with the Guatemala episode that resulted in President Clinton apologizing for Tuskegee and President Obama apologizing for the Guatemala experiments. And also joining us tonight is Attorney Michael Curry, who's the president and CEO of the League of Community Health Centers, the Massachusetts League of Community Health Centers. And he has been a leader in healthcare in Massachusetts for a number of years, has been at the League for a number of years. Prior to that, worked for Blue Cross Blue Shield, and is on the national board of the NAACP, and in fact is the chair of the advocacy committee of the NAACP. For 6 years, he was the leader of the Boston chapter, the chair of the Boston chapter of the NAACP. He is also, I could talk to you about all the things he's involved in, but I just want two things I want to point out is he's on both the City of Boston Task Force on COVID and inequities, as well as the Massachusetts Public Health Association Equity Task Force. So, and as I said, a number of other things. So he has played and I think, correct me if I'm wrong, I think you're a Massachusetts native too, are you?
Born and raised.
Born and raised in Boston, right? On last Friday, he was the recipient of the highest award that the Massachusetts Public Health Association gives, and that is the Paul Revere Award. So, and that was a wonderful ceremony, and he was so eloquent in receiving that award. So tonight, we're going to get perspectives of these two people who have different views of this. I think they share a lot, probably, in their interpretation of the significance of Tuskegee. But why don't we start with Professor Reverby? What is Tuskegee? I think, I've run into people who get the Tuskegee Airmen confused with the Tuskegee Syphilis. I think if I remember correctly, you mentioned that once in one of your writings. But we really need to know what exactly was it at a high level, and what was the components that are important for us to know about.
Right. So let's just do the who, what, where, when, and how, right? So the years are 1932 to 1972, as Dr. DiMaria just said. So 40 years, the longest non-therapeutic research study that we know of in United States history. And it starts in the 1930s because syphilis was a really important disease. And at the time, there were two things. One, the treatments that were available at the time were mostly heavy metals like mercury and bismuth and orsifenamine. And there was growing concern that, in fact, some of the consequences of taking those drugs were worse than basically living with the disease itself. And the disease had multiple stages, and it was only infectious in the first, maybe a little bit in the second, and then it would lay dormant and it could reappear years later, and it could affect pretty much every system of the body, but mostly cardiovascular complications or neurological complications. So there was a lot of interest. There was a real kind of war on syphilis, the way we talk about a war on cancer. And so there was real interest in the disease itself. And secondly, there was a belief based on very shoddy and non-existent data most of the time, that the disease was different in Blacks and whites, that the complications were cardiovascular for African Americans and neurological for whites. So in the context of this, there was a study done in a control study done in the late 1920s, which gave out actually the medicines in 6 counties in the rural South, including Macon County, Alabama, which is where Tuskegee is the county seat, about 100 miles west of Atlanta and 40 miles east of syphilis, a kind of cluster in one part of the county. So what they decided was the United States Public Health Service decided that they had what they considered, I mean, you think about these terms, kind of technically a study in nature. That is, they knew there was no money to treat these men. Most of them were poor farmers in the area. And so they set up a study beginning in 1932 in which they rounded up approximately 400 men with late stage syphilis and about 200 who were the controls who didn't have the disease. And the assumption was that they would watch them and see what happened. So they told the men that they were being treated for their bad blood, and what they were being given instead were essentially placebos, that is aspirins, iron tonics, and vitamins. And the study involved taking blood draws to see how their blood was doing, to do physicals every couple of years. And then eventually they received money to pay some of the families for a decent burial so that the body could be given for an autopsy to really look at the results of tissue damage from the syphilis. So the study goes on and on. In the 1940s, during the Second World War, some of these men would have been given some kind of treatment if they had been in the army, but the Public Health Service asked that the men not be drafted. And by the late 40s, we have evidence that penicillin, the new drug, works in early syphilis, and by the mid 50s at the latest, we have evidence that it would have helped even people in later stages of the disease. I mean, not completely, but at least it would have thwarted some of the worst symptoms of the disease. But the men were kept, the attempt was made to keep the men from treatment. So you get through the 50s, through the civil rights era, the 60s, in which Tuskegee is deeply involved in various civil rights activities. And in the 50s and 60s, a couple of physicians and epidemiologists wrote letters to the Public Health Service and said, look, what are you doing? Why is this still going on? But they said, look, this is our kind of last chance to have this, because they realized the disease might go away. My favorite line on this is a physician at Hopkins who said, syphilis will go away, he wrote in 1953, with all its secrets withheld from us. So for those of you who do research, you can imagine for a moment, if your whole life has been devoted, say if your whole life had been devoted to doing work on AIDS, and tomorrow we had a one-shot thing that would make it go away, and maybe even a vaccine that would make it, nobody would get it. So all of the money that for the research, the millions of dollars and all those decades of your research life, with all these questions still unanswered, would dry up and you couldn't continue the research. And that's kind of what was happening with STDs in the 50s and early 60s. Then they thought it would really just sort of fade away. Of course, it hasn't, but that was the fear. So I think they held on to this pocket of men in part because they didn't think they'd ever be able to recreate this study. And they didn't keep it secret. That's the part that's so interesting. There were at least 13 articles written in various medical journals over those years. Although by the 50s, the men are being referred to as volunteers. So it would be a little hard to know whether or not whether there'd been any kind of information to the men telling them what exactly had happened. But then a young sexually diseased investigator in San Francisco read one of these reports and he got really freaked out because he was doing all this work in the Tenderloin in one of the tough neighborhoods of San Francisco. And he couldn't believe that he was going out doing contact tracing for an STDs. And here were people being left untreated. And he was kind of horrified by the whole story. So he started to talk to people. He made enough noise that he was brought to the CDC in 1968 or so to talk to them, and was given kind of a lecture about he didn't really understand research and he should go home. And by then he'd gone to law school and he was doing other things, but he had a girlfriend who was a reporter. And so he gave the story to her. It went up the chain at the Associated Press, and a more senior reporter named Jean Heller was given the story. And so it broke in July of 1972, so almost 49 years ago next month. And then all hell broke loose, because by then, starting in the late 1960s, there was beginning to be realization that, of course, the mistakes being made and the misuse of subjects in research studies was not merely, the bad guys, the crazy scientists off on some island somewhere, but in fact was being done by, good-hearted and supposedly appropriately trained physicians. So Tuskegee becomes the biggest of a whole series of sort of horror stories that are reported out that were being done. And we get a national commission called the Belmont Commission, and the move toward having more institutional review boards and more informed consent and more protection for subjects of medical research. So that's the sort of brief story. The only other thing I'd add is that, at least in my research, one of the things I found, and I emphasized in the book that I wrote about this, is that it wasn't a concentration camp. It is the South. A lot of people were part of the Great Migration of African Americans out of the rural South in the interwar and then post-war years. And some of the men got to places where they would have been given, in the 50s, people got penicillin, if you got to a doctor and you were sneezing. So a lot of the men, I think, actually who survived into the antibiotic era actually got some treatment, whether it was too late to really thwart the disease, but we at least know that some of them did. And sometimes it just happened haphazardly. So one of the men in the study, Mr. Shaw, who becomes the spokesman for the men at the apology that President Clinton gave in 1997. So Mr. Shaw lived about 10 or 15 miles outside of Tuskegee, and he got pneumonia in the early 50s. And so he was put in a local hospital, and he was given 10 days of intravenous penicillin for his pneumonia, and he died, at 94. So, it's just those kind of haphazard things, but I think we have to really think about what the intention was. And then the last thing I'd say now as an introduction is that once the study was public, it never stayed in the realm of kind of just a medical report. It immediately became the subject of rumors and worries. And then it blossoms into movies and plays and poetry and music. There's a wonderful jazz saxophonist named Don Byron, whose first CD is called Tuskegee Experiments, for example. So they're all this kind of music. There's a play or a movie some of you may have seen in the 90s called Miss Evers' Boys that was based at a fictional of the study. So the study then lives on in the African-American imagination and in bioethics training for the next 4 decades now, almost 5 decades now. So it has this life of its own, and as Dr. DiMaria put it, it's become this metaphor. So the best example I can give of how it gets used is on 2 different Saturday Night Live routines. So in 2006, there was a routine in which Kenan Thompson is playing a Black patient, and he's being offered, medicine. He's broken his leg. It's something pretty straightforward. And he looks at the white doctor and he said, well, I'm not doing this. And the doctor says, well, why not? And he says, Tuskegee, as if that's all he has to say. And you would understand that he doesn't trust this white physician. And then about a month ago, Daniel Kaluuya, who you may remember from Black Panther, plays a Black physician trying to get his relatives to take the COVID vaccine. And at one point is a whole series of reasons of why they are saying they're not going to do it. And then he asks one of his cousins, well, why won't you do it? And she says, well, does it have syphilis in it? And he goes, well, why would it have syphilis in the vaccine? And she says, well, Tuskegee. And then the other cousin says, well, I'm not going to take it because white people don't take it. And the doctor says, but of course white people take it. And then he says, well, I don't trust white people. And then the cousin again says, so the doctor says, well, why don't you trust white people? And the cousin says, Tuskegee. And so the doctor says, well, it was a long time ago, right? And you're right to worry about it. But again, this idea that somehow the men were infected by the government then continues to live on. So the last thing I want to say about that is that I think it's really important to understand that if they hadn't been infecting, then it makes it really kind of monstrous. And it's like some crazed mad scientist is off, in the rural South doing these terrible things. But if you think about it, all they were really doing is denying treatment. They were lying, but they also were denying treatment. So if you think about how many millions of Americans, essentially because they can't afford it or for a variety of reasons have no access to healthcare, what was happening to these men in Tuskegee was very common and speaks to the structural racism of our country in which people cannot get decent healthcare. And I think that's what makes it more important to understand it. And then the last thing I'll say is when the HBO made these 2 movies, it made a movie also about the Tuskegee Airmen, which was a program in Tuskegee to train Black men to be pilots. And in fact, my father-in-law was the supply officer for the Tuskegee Airmen, and my husband's parents were actually married in Tuskegee because they were both in the Army Air Force. But there was a movie with Lawrence Fishburne in it about the Tuskegee Airmen at the same month or 2 that there was a movie about Tuskegee and the syphilis study. And so I think the confusion just happens all the time. And I once did Black Talk Radio in Chicago, and this man called me up and he said, well, I'm one of the airmen and we were given syphilis. And I said, I didn't even know where to begin to unpack what had really happened. So you can see where the facticity leaks into the concerns and the worry that people have, all of which is a totally reasonable concern.
Thank you. And now, Ms. Curry, could you talk about the legacy of Tuskegee for the African-American community? When did you first hear about it growing up, and what impact has it had around this issue of access to care and malfeasance on the part of medicine and the government?
Thank you, Alfred. So first and foremost, thank you to the museum for having the conversation tonight. I have become in just a few months a huge fan of Susan's, and I sing her praises anywhere and everywhere I go about her work and her research. and quite frankly, her connection to the work that I do for community health centers. She knows the founders of this movement that I get to lead in Massachusetts. So every chance I get an opportunity to sit with her and share some stories and learn more is a great opportunity. I also want to acknowledge, as I recognize the museum and Susan and you, Alfred, for moderating this conversation. I did notice Simone Wiles, Dr. Simone Wiles, who's on the call as well, and just want to acknowledge her work as an epidemiologist at South Shore Health, as a solid, consistent, important voice throughout this pandemic. So I just want to, and there are many people I could name that have been important throughout, but Dr. Wiles is just one that I've become a groupie of Susan's and Dr. Wiles as well. So that being said, I think to your question, Alfred, I think, it's funny, we don't know a lot, right? In the African-American community, we, go through life and we have these experiences and we distrust and we doubt and we fear and we're angry, and there's not often context to it, right? We don't always know about COINTELPRO and the targeting of Black activists. We don't always know about the taint of healthcare in our healthcare system. We may not know, as Susan talks about often, who Anarcho Lucy and Betsy are. And we may not know who J. Marion Sims is or Henrietta Lacks. Those are names that typically in our communities, unless there is some Black activist group that is raising the consciousness of a community, those names are remote to you. You don't know those names. So to answer your question, Alfred, I didn't know those names until I left Roxbury, Massachusetts, the child raised in a housing project, and went to college in Minneapolis, St. Paul, and became a Black Studies minor student or studies student, and had a chance to sit in classes where we discuss mass incarceration, the taint of health, racism in our healthcare system, debt peonage and restrictive covenants and redlining, right? All these things that are foreign to you, you just experience them, whether you're Southside Chicago or St. Louis or LA or Miami or Houston. And it wasn't until I got to college, I got the context, which is why the work that Susan and I do is so important. Context is critical, because otherwise you say to yourself, what's wrong with us? That's the question that is naturally born out of communities where you're mass incarcerated, you're dying at higher rates, you're incarcerated, you're stopped in department stores, the police are pulling you over. You say, okay, something has to be wrong with us, because it looks this way in Dorchester and Roxbury, and it looks this way when I visit family across the country. When I was exposed to the story of Tuskegee syphilis, I was angry. Like a lot of Black activists on campuses, right? We get angry because we were robbed. We didn't get it in grade school. We didn't get it in high school. Teachers didn't talk about it. No matter how nice they were, no matter how unracist they thought they were, they avoided that history. Now, some may not have known it, but I think, inherent in our education system is no one wants to talk about the past when it comes to African Americans, but we can talk about the past when it comes to everything else. Right? Context matters with everything else. So you don't want to talk about Nat Turner, because that was a slave revolt, right? Because we don't want Black folks being angry and revolting. So Tuskegee syphilis is one. I think about sterilization. I think about birth control. During slavery, slave masters wanted to produce slaves, right? They wanted Black women to, en masse, make babies. And after slavery, they wanted to slow that down and present Black power, Black influence. And there was a concerted effort to slow that down. We don't want you having babies. We want to really push birth control and population control. I mean, I think the critical point, Alfred, I would raise to this conversation is, I don't know where you've been. I don't know what rock you've been hiding under, if you've been paying attention, but none of this is new. That's what happens when you have race, prejudice, and power, is that you can influence so many things in our society, and healthcare is just one of them. So it's not just about determining who gets insurance or who gets care, or who gets what kind of care, and who gets to become a medical student, go on and become a physician. But it's also, I get to determine who has bad blood. All right, I can by the taint of race in the science, I can determine that you must be the syphilis-soaked race, because I've determined based on my ignorance that you carry syphilis because it has to be because you're Black, not, Susan, because of the environments you live in, because the lack of education and awareness that goes in your community. And just like COVID-19, you must be susceptible to COVID because there must be something wrong with you. That's what's inherent in these conversations. When in fact, it's because we are essential workers, because we live in communities with congested households, because we can't shelter in place. And quite frankly, all the same conditions that made us susceptible in Katrina to a natural disaster make us susceptible to a disease and a pandemic. So, all of this to say, I think, the challenge for us is, when do we stop having epiphanies, Susan? When can we actually say, no, this all makes sense when you understand what white supremacy is, and when you understand what systemic racism is, and how it's borne out in our own individual acts of racism, then it makes perfect sense that people have abused, experimented on, neglected, isolated, and so many other descriptions, African Americans for generations. And as Susan always reminds me, and I think this is critical, and I'll wrap it up here on that question, I talk about the past because the past is critical. I may not know Tuskegee syphilis, but I knew my mother didn't trust the hospital, or she didn't trust the clinic, or she didn't trust the doctor. And that's born out of that history, right, even if she didn't know that history. When say, I ain't letting them white folks experiment on me. I ain't letting them white folks down there treat me. So it doesn't take the consciousness of the specifics. Right. It's passed down in generations. And I know Susan and I talk about that all the time. And last but not least, there's lived experiences. I was president of NAACP for 6 years. I'm on the national board. I chair advocacy policy. I can't tell you the number of phone calls I get from people who are talking about medical abuse, neglect, mistreatment today. Right. Not 1972, not 1932, that still feel like doctors bring their racism into the operating room, or into the emergency room, or at a hospital, or any other healthcare setting, or a doctor's office. I had one of those calls just today by a leading community activist who said, Mike, this was a medical mistreatment of an African American. I need you to help us out. So this is not new. And I'm just thankful that we have folks like Susan and many others to give us context so that we have the urgency to do something about it.
So that's a good lead into Susan talking about that larger context, and maybe how we should be looking at Tuskegee in that context. How can we learn from it?
Right. So I think Michael's, you can tell we've become each other's fan club here.
You got like a road show.
Yeah, really. We actually are going to take this up. We have to take it on the road. We need a manager, Al. You available? Right.
Oh, what do you think about that?
Anyway, I think what he says is really important. I think the history matters, but his story about his mother is really critical. It really is about what people experience every day. And it's baked into the system. It's baked. I have a friend who wrote a book called Breathing Race into the Machine. And it's about how the spirometer, which measures lung capacity, was set up originally with different algorithms for Blacks and whites on the basis of no evidence whatsoever. And it gets repeated. There was a recent study in JAMA about the algorithms for lots of things. And my brother-in-law, for example, is a African-American pediatric transplant cardiologist. And he worked at Children's Hospital in Washington, where most of his patients were Black, and then he moved to Pittsburgh, where most of his patients were white. And he was told by his bosses in Pittsburgh to retitrate the drugs he was giving because it was white patients. And he said, there's no evidence for this. So, it's that, I keep joking with my husband, who's totally embarrassed by this, that I'm going to write this essay called My Husband's African Thomas Jefferson Problem, because they're from Virginia. So I basically think that all the things that go wrong with him are not because he has some long distant African ancestry. It's because somewhere in the family, Thomas Jefferson's blood runs in that family and from the plantations. And maybe all of the medical problems that might or might appear come from the white part of his heritage, like most African Americans in the United States, not as Black. So that's a way to think a little bit about these issues. But the thing about, to go back to Tuskegee, as you've asked me, is here's what I want to argue. I think obviously the importance of understanding the racism that's is central to the way the study was set up and conducted, the lack of informed consent, the lack of protection for the men. But the other historical lessons I think are really important that speak to what Michael's talking about in terms of context. So think about this. If the government had given a newly freed people the promised 40 acres and a mule, sorry, I got that wrong, 40 acres and a mule after the Civil War, then people would have been able to have a little capital accumulation. They might have been able to sell and own their own land. There wouldn't have been as much sharecropping or peonage right after the war, and they might have left. And so they wouldn't have been as vulnerable to the offers of free care that were given in Tuskegee. If they had had access to decent health insurance, they would not have been as so vulnerable. As Mr. Shaw told me right before the apology, we thought we were helping our families when we did it. If there had been more sex education, more public health, more condoms available, there wouldn't have been as much syphilis in the first place. If racist assumptions about biological difference didn't exist, the study wouldn't have been done in the first place. And then finally, I want to say something because it's a question, one of your, I want to respond to this question that's in the chat. So I want to say that even though it was mostly run by white physicians, the face of the study, as is often the case, this is how all sorts of power works, which is that you find someone from the oppressed community to be the face, the interface with the people you are dealing with. So we had Black doctors at the hospital in Tuskegee called John A. Andrew Hospital. And we had an African-American nurse named Eunice Rivers Laurie, who is the go-between the men and the public health service, and to whom most of the men related. She became what I call their private public health nurse in the study. So having racial concordance with patients and healthcare providers, of course, is never enough. We used to say early in the women's movement, before we had to deal with issues around trans people, so this is a little bit cisgendered comment, but we used to say it's not a question of who you want to sleep with, so who you're willing to die for that actually really matters in the end. So one of the people asked in the chat, so if you don't mind, Al, I'm just going to respond to this. She said, I'm baffled by the Black nurses involved in the studies. It seemed they believed the study was relevant and helpful. How is that so? So part of the focus on Eunice Rivers in a lot of the discussion of the study is for a number of reasons. First of all, there were hundreds of doctors who came back and forth. There are lots and lots of names. So she's the sort of one constant through the whole study. And in the first book by a historian, my friend James Jones, called Bad Blood, he wrote a whole chapter about Rivers because she was still alive when he was doing his research. So you get lots and lots of names, and then there's Rivers in the center. And of course, she's the only visible nurse and the only really visible woman in the story as it's told. And so there is this sort of weird expectation somehow that she could have stopped it herself. So think about this, in the center of Tuskegee, like in most southern cities until quite recently, frankly, there is a statue to a Confederate soldier put up in the central square, and Black people until the late 60s weren't even supposed to walk in front of the statue in the square in which Macon County, Alabama is 85% Black. So imagine, what would Nurse Rivers do? Stand in front of this statue and say, geez, this should stop. So they would have fired her. They would have replaced her with somebody else. So I think in a situation in which people were getting no care at all, she was providing, she gave them literally aspirins, but no, people didn't have access to aspirin. She drove them into town where some of them worked, lived in these rural communities, had never even been into Tuskegee, and it was 10 miles away. Mr. Shaw told me they were so poor during the recession, during the Depression, that they shared license tags on their trucks. So when they wanted to drive on the main highways, they had a license plate to put on the truck. So I think she thought she was doing sort of the right thing. I think she accepted that the disease might be different and that the treatment was worse than the disease. And then I found evidence, although my colleague James Jones and I argue about this all the time because he thinks I'm wrong and I think I'm right. I think she helped get guys out of the study. You know, there's an expression in the South, in the booth in the back in the corner in the dark. And I think a lot of stuff was going on behind it, because when Mr. Shaw, for example, gets told to go to Birmingham to possibly get penicillin in the 1940s, no one ever really asked him until I did. So Mr. Shaw, who told you to go get treatment, right? So I think you have to really, and he was a little confused about how it had happened, and he was 93 when I interviewed him. So, you know, I think there's enough written evidence and other evidence from people I spoke to down there to assume that there was a lot of sort of yesing in the front, but also going on, you know, behind the scenes as well. So I think it's a complicated story. And she was also, there's a Black physician whose name was Eugene Dibble, who was the head of both the hospital at Tuskegee at the Institute and then also at the Veterans Administration Hospital. And he moves back and forth. And Dibble had the good sense to die in 1968. So nobody ever got to interview him about what happened. And I wrote this chapter called Dr. Dibble's Dilemma, trying to explain why he did it. And I think part of it was that he was very much what we would call a race man. That is, he was very devoted to what was going on. He was one of the founders of the National Medical Association, Black Medical Association. He worked really hard on desegregation issues. And for those who keep up in local politics, Valerie Jarrett is a grandniece of his, and Ann Dibble Jordan, who was married to the Black power broker in Washington, Vernon Jordan, is Dibble's daughter. So he comes from this very long line of very powerful Black figures. I mean, these are the ancestors, but his own family was that. But I think he was very devoted, but I also think he was a science guy. And I think he believed the science that the disease was different in Blacks and whites. And he was interested to see whether, given very, very small resources, whether or not treatment was really super necessary or not. So it's a complicated story, and we'll never get to ask him unless, you know, we can speak to the dead at some point in the future. But right now, all I have is written material in my own kind of attempt to analyze what happened.
And Alfred, if I could just make a quick comment
Yes,
about
please.
the question in the chat as well. So to Susan's question, I think for anyone who's gotten a deeper understanding of racism, then you understand that it could be a Black cop that pulls you over because you're Black. It could be a Black doctor who treats you differently, you know, Black guidance counselor who tells you you can't go to Harvard though you have the grades to do that. It could be a Black teacher who talks down to you in the classroom. That's how insidious racism is when the people who are the subjects of that racism also believe it, right? I think that's the greatest manifestation, that there's a little girl sitting in Southside Chicago right now that thinks that she cannot be the next Kizzmekia Corbett because she's Black. So I just want to stress that sometimes we ask the question, well, I'm surprised that Black people participated. That's throughout our history, right? There were Black people who participated in our mass incarceration, in slavery, you name it. But that's the impact of power, is that when you can wield power that way, then you can even make the subjects of that of that subjugation, that racism, participate in it, internalize it. So I just wanted to stress that that should not surprise you if you understand how deep racism is in this country. And people often operate from this place of lack of consciousness. I posted, Susan, on my social media recently. I said, I'm glad so many people are woke and others are waking up, but some of us are insomniacs. and Susan's an insomniac, right? The health center founders are insomniacs. All the rest of those folks are waking up and they're reading books and they're coming to some consciousness. But I want you to know, none of this was a surprise. Somebody was saying, like Susan points out, this experiment was wrong, that it was unethical. Somebody was telling J. Marion Sims it was unethical. Somebody was challenging institutions to give slaves an opportunity through the Homestead Act and the Southern Homestead Act. This is not new. It's just people weren't listening. They weren't heeding the call, the warning. So I just wanted to stress that. we have to make sure that we have a grasp on how internalized racism can manifest itself even within Black folks.
I want to add to this because I think the current thing is really important. It's very interesting to see this attempt by the Republicans in some of the states to ban the teaching of what they're calling critical race theory, which actually comes out of some legal argumentation. But what they really want is all of the things that Michael's talking about. They don't want you to know about it. That's why they're saying this. It's not, and I mean, I grew up in this little white working class town in upstate New York. And so one of my, and we, as you can imagine, lots of arguments go on our Facebook page from my high school class. And so one of my classmates wrote, "It's really terrible that teachers are going to push propaganda in the classroom." And I wrote back to him and I said, "What do you think we were taught? We were in high school. It was all propaganda." I mean, and I'm from the generation who got to college in this, in the middle of the Vietnam War and went, wait, what? We're not the good guys, right? Really? Or, and then I got to Chicago. I worked for the Southern Christian Leadership Conference in Chicago. I did the open housing stuff. I was one of the white couples that went to look at housing, and then we would send a Black couple in right after us with the same demographic. And then we were shown houses in one place and Black people were being shown houses in a completely different neighborhood. And it was I had never seen anything like this before. It was a complete amazing experience. But I think the fight now to keep this information from people tells you how scared they are about what we're trying to talk about and why it matters.
And Susan, I have an article that I think is to be published soon, which talks about, since we're so open to conspiracies these days with the QAnons and the conservative, the right, I'd love to now dig into some of these conspiracies out of the Black community that people have sort of scoffed off for years,
right,
that are most likely true,
right,
when there's almost no basis in the rest of these conspiracies. So maybe you and I can get together, we can expose some of these truths.
Yeah, there's actually a great essay by Skip Gates that was in the New Yorker maybe 20 or 30 years ago called 13 Black Men or something. And it's about all of these kinds of conspiracy theories. And, some of them are right. The joke in my family was an old New Yorker cartoon, I think, or a Far Side, that shows a surgeon opening up the guy's stomach and out come the butterflies. And the surgeon said, "Wow, he really did have butterflies in his stomach."
One thing you reminded me of, and I forgot that apparently the first person who was reading the articles about Tuskegee and said, "What do you mean they're not being treated?" was Count Gibson.
That's correct.
Yes,
And
that's
the
exactly.
founder,
That's exactly.
went on to be the founder of the community health
He was
center.
a young physician at that point, and he was basically told by his senior people to keep his mouth shut.
Yeah.
If he didn't, and then and then to speak to also what Michael's talking. So one of the people who really tried to stop it was, we just lost him 2 years ago, is a man named Bill Jenkins. So Bill was the first. Did you know him, Al? He was the first Black epidemiologist that worked for DHEW, and then he started a really important program at Meharry to train African Americans in epidemiology and in medicine. So Bill was part of this little militant group when he was in Washington in the late 60s called Drum, and they were around a man named Ralph Featherstone. I don't know if that name is familiar to you, Michael, but these were people who were on the edges of Black power. And Featherstone was on his way to a hearing for H. Rap Brown, the leader, one of the Black Power leaders, and he was killed. There was a bomb in the car, and it's never been clear whether he was carrying the bomb or whether the FBI basically blew him up. So at that point, the group falls apart, and Bill is never able to get any attention to the thing in Tuskegee. And then later in life, which is so interesting, he becomes. So one of the things that happens as kind of semi-reparations for the study is that the men and their families and the women and children who were still positive got lifetime medical care. And Bill was in charge of the program at CDC. And then he goes on to make sure that it changes from a medical care program to a healthcare program, which meant that if you needed to have long-term care in a nursing home, the government paid for it. So
I think we can see now that Tuskegee is a horrible symptom of a larger
that's correct.
problem, and I think that's obvious. It's been obvious, and I think there's a lot of people on this webinar who are learning about this, know this, but then are in their daily life have to deal with getting people access to care when there's limited access, or what access there is compromised by concerns that they have, or the same thing with vaccine hesitancy. So what can we do in the short term to address these immediate problems, and still yet address the big issue?
Michael, do you want to talk about the community health centers and what you guys are doing?
Yeah, so I'll start with that and maybe even a little broader. So one is community health centers, and Susan, you'll appreciate this. I did an opening for the conference today. We started our 3-day community health center conference, which Susan opened up. And my comment was, we were born for a moment such as this. That this is what Jack Geiger, Count Gibson, Dr. Hatch, and Dr. Smith, and many others had envisioned. It wasn't just about that moment in 1965. It wasn't just about Columbia Point or Mount Bayou, Mississippi. It was about the fact that they understood the vulnerability of the communities they were trying to bring healthcare to. They understood it was about water, clean water. It was about economic power and access to employment, that it was about food and housing security. They understood that. I mean, they were before their times, quite frankly, Alfred. It actually shocks me. If people go back to the original foundings of the community health center movement, they'd say, wow, they were talking about social determinants of health back then. We just didn't call it that. So, I think that, we've been in this moment in the last year of really revisiting our mission, and advocacy has been part of that. How do you demand that there be testing in your communities when folks don't get equity right? No surprise, we don't get equity right. How do you make sure you have a seat at the table when they're talking about crisis standards of care? And it could be a decision on who gets a ventilator based on comorbidities, which would have impacted the communities we serve that have higher comorbidities. How do you make sure that we don't have health centers closed by demanding and asking for resources to make sure that the precipitous decline in revenue doesn't mean that we lose community health centers in the communities most impacted? Imagine in communities like Lawrence and Lynn and Chelsea and East Boston, if a health center had closed because of all that revenue decline, and there wasn't there over the last year to meet the demands of testing, contact tracing, and now vaccinations. So there was a lot of work that happened over the last year. And quite frankly, I know we celebrate hospital physicians and hospital workers. I ask all of you on the call to not forget about community providers, community health providers, community health center providers. It's always emotional for me, Susan, when I'm in an airport and people applaud a military person when they walk through. We now need to applaud our first responders and our medical folks, because quite frankly, they risked their lives, and community health centers did the same. Now, the broader issue, the crisis has refocused us on health inequities. So, and I'm gonna say this in a way that we would say it back in our community in Roxbury, everybody and their mama is looking to deal with health equity now, right? Not that they will stay here, but it's a great thing that they're here for the moment. But how do we seize that opportunity, carpe diem, to make sure that we deal with the underlying issues that make people unhealthy? How do we deal with the food and housing insecurity, the racism? How do we deal with the mass incarceration? How do we deal with racial profiling? The collection of all that is why people are unhealthy and they don't trust us. Right. And I say that collectively, us. So I think that there is a concerted effort. I talked to Ron Mariano, the Speaker of the House, and Senate President Spilka, and I've talked to the governor and the Secretary of Health and Human Services, and I've been on phones with HRSA and the Bureau of Primary Health Care. I mean, I've never seen this concerted focus, Susan, in a long time, I mean, ever in my years of doing policy, right, around health equity. But it won't last unless we demand that it does.
That's right.
And I think thankful for Susan and folks who are willing to do that.
Yeah, no, one of the things I've been doing, because of the last book that I did after I did the work on Tuskegee was about an American physician who was a leading health advocate for in HIV/AIDS, but he also had been a political prisoner of the United States, frankly, and almost died in prison. And so I've been working with a group in New York called Release Aging People in Prison. We're trying to fight for decarceration of elders in prison. And in part, I'm part of the public health group around that. So there are ways in which our expertise in history or in public health or can actually try to put pressure. We're really hoping we can get these bills on parole justice and elder release through the New York State legislature, you know, now. So I think there are things like that. And I think what Michael's saying is now we have a moment right now because people are realizing that if the grocery store clerk gets sick, then I can get sick, right? You can't keep hiding in your house or your apartment forever. And everybody we're all in this, you know, as the expression goes, we're all in the stream, we're just in different boats. But I think it really matters how much we keep working with organizations that Michael is part of to help keep this in front of the legislature and think about the ways in which we seize this moment and put pressure on people to understand the basic reasons for why this inequities exist. I mean, the best health insurance program we could have would be to give people decent jobs. You know, that would be the most important thing we could do, was to help people get education and get decent jobs.
Let me ask, so how did the Tuskegee go on for 40 years, and what's to prevent this from happening again?
Right. Well, it went on for 40 years, in part, as I said, there's a very interesting article that's in my edited book about the articles about how people talk about it. It's about the language. So you use this kind of weird passive construction, or you say that the men were volunteers. So when you read a research study, you don't know what the IRB report looked like. You don't know what kind of consent people really gave and whether it was freely given or not. Or in the case of Tuskegee, the only written consent was to have the autopsy. Everybody, not other than that, there was no, and it was a period in which really consenting didn't really happen in that way. I mean, my father was a small town physician, for example, but he did some of the early work on penicillin in a hospital in Chicago about bacterial endocarditis, which at that point was a death sentence. So he's trying out this new drug, penicillin, in 1946. So I said to him before he passed, so Dad, what kind of consent did you get from the patients? And he said, well, I told the patient if they didn't try this new drug, they'd die. Now, that kind of wouldn't work right now, but it gives you a sense. I mean, at least he was being straightforward and honest, right, with his patients about what he was trying. But, you know, it's an example of, so I think part of it is a whole thing. And I think when you listen to the physician, a man named John Cutler, who ran the study in the 1950s, when Cutler's on camera in 1992 about the study, he says, well, we were as I said earlier, we were in a war against syphilis. So I think people accept that in the time of war, you have to make certain kinds of hard decisions. And so I think it just kept going. So there are even leading Black public health people who said, look, I taught this at Howard. I understood that the study was ongoing, and it never dawned on me that there was anything wrong with it. So I think it speaks to what Michael said earlier about you accept a certain amount of thinking about the ways in which you do this kind of work, and you don't ask the questions. You know, you just don't see it. It's not visible. So, you know, it's all about, you know, there's a great line from Pester. He says, chance favors the prepared mind. So if your mind is not prepared to see something, then it just isn't visible. And honestly, they really didn't think they were doing anything wrong, which is what Cutler said in 1992, which I thought was just stunning, right? So that's how it keeps going. And because they held on to their data set, right? So I can't see the questions. Can you read if there are other questions, Al, that we should be answering?
So, you know, I just want to say, so, you know, I think people look at something like Tuskegee, and I think you pointed this out, and think, well, these were like people who were racist, and they were doing it, you know, and I think they would have been offended if they were told that.
Right. No, I think that that's right. So what haunts me in all of this is when my friend Jim Jones, again, was doing his research, he told me this story. He interviewed one of the physicians who ran the study, and he said to him, well, after 1946, didn't Nuremberg give you pause? That is the code and the beginnings of looking at what the Nazi doctors were doing, you know, in the concentration camps. And this physician looked at Jim like he was out of his mind. And he said to him, but they were Nazis. So the famous bioethicist Jay Katz says Nuremberg is seen as a code for barbarians, right? So the problem is, if you think about Tuskegee as something that happened in a universe far, far away at a different moment in time, you know, blah, blah, blah. I'm a good guy. I would never do that. And so when I talk to medical audiences, I often say, it's not that you just shouldn't be like Dr. Cutler. You should try to think about how easy it would be to be him. That how easy it is to get caught up in the day-to-day of your work, or convinced that what you're doing is so important that you cut these kinds of corners, or you think this is okay. So that's what I think I feel like my responsibility as a white historian is to talk to medical professionals about that kind of way of thinking, so that we don't put Tuskegee in the same box as we put Mengele and the Nazi physicians.
And Alfred, one of the things that I think is a powerful outgrowth or born out of, I should say, the last year with George Floyd's murder is that phrase, and actually prior to that, the whole Black Lives Matter movement is that Black Lives Matter. What Tuskegee Syphilis experiment points out is that Black lives didn't matter. That's why they didn't get treated for their syphilis. J. Marion Sims didn't treat those women with anesthesia because Black lives didn't matter. We have a lot of examples. If we're willing to now in this moment go back and unwrap that, there's a lot of examples of Black lives not mattering then and now. So if you're on this call and you're a white male or female and you are the predominance in our medical schools and our C-suites, you run education policy and housing policy in this country, and you think that everyone who does this kind of stuff is evil, then you missed the story. They weren't evil, right? They worked for their PTA. They may have given to the United Negro College Fund, but racism doesn't work like that. Racism manifests itself in our decisions all the time, and I think part of what we got to do is unwrap that and understand that you too could be that racist. And it doesn't mean that you harbor racial animus in your heart, although, Susan, I would argue we get too into this implicit bias thing that people just trip over their prejudices, when in fact, I would argue a good percentage of 7.4 million people have racial animus in their hearts, because otherwise you wouldn't have voted that way.
Right.
That's my argument. You don't have to have that. But I believe that after all we saw over the course of 4 years and you voted that way, then you're harboring racial animus because you created a Faustian bargain and you turned a blind eye on all of that racial hatred under that administration. So understand that they're teachers, they're doctors, they're lawyers, they're scientists, they're epidemiologists, right? They're crossing guards, right? And they're manifesting those beliefs all the time in their jobs. So I think we just have a real reckoning in this moment around race and how it plays out in our own lives. How we even walk in and operate off of that white supremacy and off of that racial concept, and it's impacting our society. So I don't want us to relegate this to the Nazis or to the slave masters, because we all have something to unwrap in our own lives to figure out how we're complicit with this.
That's right.
Okay, so we do have some questions, and people can put their questions in the Q&A box or in the chat. And the speakers can see the chat, I think, and I can do the Q&A. Can you speak about the Black Panther Party's free medical clinics attempting to address an unmet need and how they were thwarted by and large? I wish I knew more about that history.
Right. So the best way to do that is Alondra Nelson has a wonderful book called Body and Soul, which is on the history of the Black Panther Party free clinics that they started and the importance of the work they did, especially around sickle cell. But, eventually, as we all know, free clinics are very hard to sustain, even if the FBI isn't constantly infiltrating your group or killing your leadership, as we know from what happened to Fred Hampton and possibly for Ralph Featherstone that I mentioned earlier, and God knows how many others. So the Panthers really did, and frankly, a lot of the Panther women did this work. There's a lot of work being done around these issues. There's a whole Black Women's Health network. I work with a former student of mine, runs something in Boston called the Resilient Sisterhood Project that works with mostly Haitian Americans around reproductive health issues in the African American and Haitian American community here in Boston, with lots of different kinds of programs around that. So I think there's always been a kind of meet groups within the Black community separate from what was going on in traditional institutions to trying to make these kinds of things happen. But again, Alondra's book, Body and Soul, is a really good way to get a handle on the history of what the Panthers were doing.
A comment and a question from Stephen Young. First of all, he wanted to comment about Michael's comments about let me get.
Well, I want me to read it out loud. I can see his question right here.
The Q&A?
Yeah, you want me to read it?
Yeah.
So Stephen Young says, how do you deal with doctors who don't believe there is racism in medicine, in their institutions, in themselves as doctors? It happens a lot in the South, but there's of course some in the North and in the West and in liberal institutions. Of course there is. So one of the things that just happened, I don't know if some of you are familiar with this debate, but JAMA, the Journal of the American Medical Association, did a podcast a couple of months ago in which this guy, I mean, frankly, as a Jewish American, I have to say completely embarrassed, as my mother would say, not in front of the goyim. So he wrote this podcast in which he said, I'm a Jew, I'm not racist. There's no such thing as structural racism. And the whole world blew up around him. And just last week, JAMA fired essentially the editor of the journal around this issue. And then someone else did a study. I have the citations. If someone wants to just write me, I can give it to them. And I'm just sreverby@wellesley.edu. But in this study, they looked at the use of the terms of racism in medical journals, and it only in the American Journal of Public Health does it really get discussed in any major way. No surprise, but not in JAMA, not in the New England Journal, not in the British Medical Journal, not in Internal Medicine, not in all the major journals. So I think this is very narrow, except in public health, understanding, about what counts as healthcare and why you don't talk about structural racism. But I think the fact that this guy got fired is really interesting, or that these articles are starting to be. So I think we're in a moment where we have to really help people think about what Michael's saying. That is, you don't have to even treat your patients badly to have breathed into your very being all of these beliefs that you have to unlearn. There was a great line in the women's movement that I used to quote all the time in my syllabus, which was, she said, it's very hard to fight an enemy who has outposts in your mind. And so the problem is you have to find it. You have to, that's what consciousness raising was about. It was about trying to find the enemy in your head and think about and expose it and think about it. So the same thing around racism, and that's the literature around unconscious, but it's baked in. I think we're trying to help people understand. It's baked into the algorithms. It's baked into the understandings. It's every time my husband goes to the doctor and they say, because you're African-American, blah, 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 not because of a whole lot of other reasons that would be the obvious explanations for what's going on. So, things like that are just what people have been taught. Think about the way we describe patients, how we think about them, what we've done. So I think what's hopeful is that I think this new, first of all, we have much more diversity. I mean, it's not a guarantee, but we have more diversity now in medical schools than we had, 40 years ago. We have many more students starting to be aware of this. The Black Lives Matter movement, I think, has also hit the medical schools and medical practices, and people are beginning to ask those kinds of questions. So I'm at least hopeful, but I agree with Michael about worrying about all the people. I mean, I have the same thing in my, it's classic in my own family. My brother, the physician, voted for Trump twice. And there's just, and when you try to argue with him, it's that, well, if you say X, he says, well, Obama did Y. It's, and you can't argue. There's no fact, we're like this. And I've been trying for years and it's just impossible. And, in some people, you just have to give up on and just hope you can contain them. That's all.
Well, to that question around and the question Q&A around how do we reach our doctors, right? And again, I make this broader. How do we reach our teachers? How do we reach our politicians? I think that a big part of that, which is why I appreciate Susan so much and the Skip Gateses of the world and so many others, the historians, is that, when I was a student in college in Minneapolis, St. Paul at Macalester, one of my professors said, give people the information. And oftentimes they'll argue with you, they'll debate with you, but then come back 5 years later and they'll be repeating what you said to somebody else. But you got to wait on it.
Yeah.
And I think part of what we've not done is have these frank, honest, science-based, history-based conversations so that those medical students don't believe that Black people have higher thresholds of pain, right? There's recent studies that show that medical students believe that Black people have higher thresholds of pain. Today, right, in the last decade or so, we're not talking about J. Marion Sims, right, in the end of the 19th century. So I think part of that is how do you bring these conversations to the classroom, to the community, to our households in a way that next doctor, that next lawyer, that next CEO comes in with a consciousness of that stuff and makes different choices. Now that's the future. But I also say, let's challenge, we all have a seat at the table. We have to challenge our loved ones, our colleagues in the boardroom or in the medical school or in the operating room, challenge people to do this better and to do this in a more equitable way. And I always say this, Susan, and you would appreciate this more than most. Speaking truth to power comes with great risk.
Okay.
You can be fired. You could be labeled a militant or you just don't fit in. Trust me. I mean, I'm a student of history when it comes to Black activism. And now all those folks who've been saying that stuff that literally for decades, for centuries, now all of a sudden I have white folks saying it to me as if it's a new thing, but yet they were demonized 10, 15, 20, 30 years ago for saying the same exact thing. So we are in this place now where now we know we have the power that comes with great risk to challenge institutions and attitudes. And I'm hoping and praying sincerely that we all embrace that responsibility and that opportunity and start doing it. So that's not just the activists doing it. You can do it with grandma, grandpa, mom or dad, or with your uncle or aunt, and you can challenge them on their racism, particularly as we're talking about today, as it impacts our healthcare system.
Exactly.
I thought I couldn't be shocked by things that happen, but the announcement this weekend about the NFL having their, having cognitive grading different by race was like the NFL.
Yep.
It's it's sort of, if that can happen, yeah, a lot worse can happen too.
Mm-hmm.
Question. All right. So there's a question about Henrietta Lacks.
Okay.
And about a professor saying that the result of her cells being used saved a lot of lives, did a lot of good. And then a related question of what happened, did the Tuskegee studies result in something that wound up helping people?
No.
Susan, before you jump on this, only because I find that, and not that the person, this is not an indictment on the person who asked the question, but just it's always repulsive to me. You can make the argument that the slavery was good for the American economy, right? That 4 million slaves created wealth for individuals and built our institutions and our railroads and our railways. These are casual, and Susan, when you talked this morning in our panel discussion, on our discussion for the Mass League, you referenced this as a war, right? The war against some of these illnesses or whatever. And I thought to myself that it's only when you're covered in racism that you determine who the casualties of that war will be.
That's correct.
So it's not like, hey, I'm choosing people who look like me to be casualties. It's the peoples whose lives don't matter that you decide that you're going to be subject of my experimentation, that I'm going to get you in my study without consent, without you being an informed patient, and I'm going to take advantage of you. And whether that's Tuskegee or Africa, because quite frankly, Africa is low-hanging fruit for people who want to do experimentation as well.
Right.
So, Susan, I just wanted to tee that up because I thought about that this morning.
No, I absolutely agree. So in terms of the science itself, there's actually an article in the edited book I did, which tried to look at it. And the problem was the study itself was a mess. So it wasn't so easy. The blood tests were kind of a little iffy, and the samples sometimes were left out in the sun. You know, it's Alabama. There wasn't a lot of ice all the time. Wasn't a great refrigeration. So some of the stuff degraded. So we don't even know if some of the men who were deemed positive, in fact, had syphilis at all. And that's in part why the autopsies became so important, because they were looking for tissue damage. And then you'll love this, at least 12 men who at autopsy showed that they didn't have syphilis were literally moved into the control arm. Right. This is like how you flunk doing research 101, right? But people in the control arm who got syphilis weren't moved into the syphilitic arm. So in terms of the science itself and the statistics, it's a mess. I think what it taught us was about racism. And that is what we learned from it, that and about racism in medicine. That's its lesson. But in terms of the science itself, absolutely nothing.
Okay, I don't see other questions. And I think, I'd like to give an opportunity for some last words.
Well, I'll start then. I just want to echo everything that Michael's been saying. I think this is a really crucial moment, I think. And I think we can't afford to forget. We really can't. We all have to stay vigilant. We have to stay committed. We have to stay pushing for looking at the reasons for health inequities. We have to remind people all the time that this has to be this is the real infrastructure. Frankly, you want to argue about whether daycare counts as infrastructure. I want to argue anti-racism is the most important infrastructure that we ought to be building right now.
And the only thing I would end it on is one of my favorite African proverbs, which is, hunters will cease being heroes when lions have historians. Hunters will cease being heroes when lions have historians, right? It's the hunter that has the grand story about how they killed a lion, but there's not a lot of stories about how the lion survived and was resilient and fought back. And I thank God for the Susan Reverbys of the world, who are now the historians for the lions. There is so much untapped. We overstate, not overstate's not the right, we over talk about J. Marion Sims and Tuskegee and Henrietta Lacks, when in fact, there's so much more to talk about, so much more to discover about experimentation, abuse, and neglect. And I often said, Susan, white institutions did not want to do this research because if they did, then they'd have to do something about it.
Yeah.
That there's a responsibility that comes with knowing the truth. And folks choose not to know the truth because it comes with an obligation. And I think it's now time, Alfred, that we start investing in and supporting research into the truth. How did we get here so that that little Black boy, like I did growing up in Lenox Street housing projects, doesn't think something's wrong with us? Because quite frankly, something was wrong with America. And until we tell that story and take that burden out of the hearts and minds of African-American and people of color across this country, then we have a problem. And I'm just anxious for us to start. I mean, aside from all the policy work we need to do, all the stuff that we do in community health centers, the history matters to me because we've never had the context. And then that'll inform what we need to do going forward. So, thank you, Alfred, Susan. Anytime Susan, if there's a panel discussion that Susan's on, I would gladly second seat for her on any panel.
Well, I feel the same way.
Well, this was a wonderful discussion. Thank you so much. We're getting a lot of great reviews here in the chat, and I really appreciate it. And the museum appreciates it, and we hope that we can do something about this in the museum too, in a small way.
Yeah, let's
to-
let's talk about it going forward, because you have a great opportunity there to really, I can actually loan you my little vials of arsifetamine and bismuth that I bought on eBay. You can even show what they didn't get.
Right, and as I said, I have great interest in William Augustus Hinton, and it's fascinating to me. He was a prominent African-American physician, researcher, expert in serology and microbiology, and apparently a very wonderful man, which I was hearing about today. And I thought, I knew that already, but he was a consultant to the Public Health Service on syphilis.
Oh, I know. There's the Hinton test. It was
Yes,
one of
he
the
must have known about this.
Yeah.
And there's nothing in our records or anything we can find that comments it on at all. And it's a mystery, just like the mystery about why he's the only person to reject the Spingarn medal.
Well, anyway, to be continued.
Yes, thank you. Thank you both.
Good night. Thank you very
Really
much.
you.
appreciate it. Good night, everyone.
Good night. Bye,
Thank
everybody.
you.
Thank you.
Visit the museum website